Hello, everyone. Hi, I'm Kelly. I'm the marketing manager at the Cleveland Hip and Knee Institute. It's noon, so I thought we would get started. If everyone could please make sure they're muted. You were supposed to be muted when you started when we started the meeting, but I don't think we all are. This is the free online webinar, Kinematic Knee Replacement, Restoring Your Natural Knee Alignment with Dr. Nicholas Callahan. He's going to talk for about a half an hour, and then we will have time for questions at the end. So if everyone could please use the chat feature at the bottom of their screen, there's an icon with a bubble, like a talking bubble, and it says chat. So at the end of the presentation, you will have the time to ask questions. And I'm going to let Dr. Callahan now take it away.
Thanks, Kelly. Appreciate it. So I think I'm not sure exactly where that mute function went through on that. But yeah, if everybody could just please make sure you mute yourself just because there would be people coming in and out. And if you're in the background or somebody's mowing the lawn or you have your blender going or whatever, we're going to be able to all hear that. And hopefully nobody is using the toilet or anything and we have to hear that. Anyway, without further ado, thank you so much for coming in and participating today. We really appreciate your time this afternoon. I'm going to talk to you about kinematic joint replacement, a natural way to do the knee. What we'll do next is we're going to get you my PowerPoint up here. Okay. All right. So kinematic knee replacement surgery is really a way to restore your natural knee alignment. And so, excuse me, there we go. First, I want to disclose that there's no relevant financial disclosures or conflicts of interest related to this talk. And the disclaimer just to be that this is a general overview. This is not the time to ask your personal questions. It's not a personal consultation. Please try to be mindful of that when you ask your questions. I'm happy to answer all of those personal questions, but it's better to be dealt with in an office setting where we can have some privacy with that. So what I first like to share with you is one of my patients. Is that maybe you could recognize this type of symptoms or this type of x-rays if you've ever seen before. But this 75-year-old gentleman came into me with severe pain in his knees. It's been really difficult to live his life. Nothing seems to be working anymore. He stopped being able to have the effect of having pain relief from anti-inflammatories, like ibuprofen or Aleve. Tylenol's not working. He's tried multiple injections. Nothing's making it work anymore. So he's in a lot of pain and he's coming in to see me. So our course for today, we're going to go over what's basic knee anatomy, what's arthritis, and then what, of course, is kinematic joint replacement. By the end of this talk, I want you to understand that there's two kind of pathways or main real ways of thinking about doing a knee replacement. There's the conventional way and there's the kinematic way, and that's my way of doing knee replacements. And I want you to understand that the conventional way is sort of like forcing a square peg in a round hole. And as we know, that's not something that is ideal. So I'd like to start off my whole presentation, just give special thanks. You know, one thing you do when you're in training is you stand on the shoulders of the giants that came before you. And these two surgeons, Dr. Molly and Dr. Frendak, learned so many great things from not just doing kinematic knee replacements, but really being a great physician in person. So I like to thank them for that. So another thing about me is that I grew up in Northeast Ohio. So I'm a local born and raised guy. I grew up in Amherst, went to Baldwin Wallace College, went to Lake Erie College of Osteopathic Medicine, and spent some time in Western Pennsylvania, so in the region. And I learned my advanced technique with in the Whole Health Joint Replacement Institute. So yes, this does make me a Cleveland Cavs fan, a Guardians fan, or Indians, however you think about them, and at times, unfortunately, a Browns fan. Why do I do this? Well, first off, I love this. And, I'm just so lucky to be able to help people just like you. And every time I have a patient that comes in, like my 75-year-old gentleman that came in with those knees, I know that we can do better, and I know that we can make him better. And so I'm very passionate about doing that. And the way that I do that, I'm very excited because the types of outcomes we're getting is so fantastic. So first, we'll talk about knee anatomy, because you got to kind of understand a little bit of what we're dealing with or what we're talking about in order to understand how we affect those changes with arthritis and how do we make the knee function and move better. So first, the knee is made up of 3 bones, majorly the femur bone, which is your thigh bone, the kneecap bone, which is your patella, and the tibia bone, which is your shin bone. And on that joint surface, there's cartilage. And cartilage is the slippery, firm substance that your joint I'd please like to remind everybody to stay on mute if you can, and make sure you check that, please. The joint cartilage is firm and slippery, so this has no nerve endings on it. And when it wears away, the bone that gets exposed has a lot of nerve endings on it. And so those bones start to touch, and that can cause swelling and pain, and it can make your knee really, really miserable. As you bend and straighten your knee, those bone ends touch, it can cause a lot of pain. It can be sharp at times, and sometimes it can be something that's more like a dull toothache. Either way, those types of symptoms tend to progress over time. So when we evaluate this, we get x-rays in office, and what we see on the left is an example of a knee that has and that arthritis free joint has a good black space there. There's no bone touching. The bone is uniform. It doesn't have any white, extra white or bone spurs on it. It looks like a normal knee. It looks like a healthy knee. As we progress with arthritis, the bones start to touch, you get bone spurs, and the joint space goes away and disappears. And that can be a sign of a very painful knee. What happen? Well, wear and tear arthritis is the most common. You start to wear the joint and it swells, and the cartilage on the end of the bone wears off. There's also inflammatory arthritis from different types of medical conditions. And if you injure your knee, you can injure the cartilage itself. So after a fall or a fracture, that can cause arthritis. That pain, stiffness, and swelling, and losing your range of motion, all those things are symptoms of arthritis. So what you have to understand, that's important to understand when you do a knee replacement, is that not everybody has the exact same alignment of their limb. So if you've seen people walk around, you've seen them at the grocery store, at church, or maybe at the golf course, you can see some people have a straight leg, but a lot of people have some form of, maybe they're a little bow-legged, or maybe they're a little knock-kneed. So not everybody comes in one size fits all. And we know this because we've done studies on this and looked and seen that there are people who don't have any arthritis, young, healthy people that don't have any signs or symptoms of arthritis. And if you get an x-ray, it looks like exactly the one we showed before. There's no bone spurs, there's no joint space that's narrowed, and they still have a little slight bow leg or a little bit knock-kneed. And that's a normal alignment for them. So that's important to remember when we think about arthritis, because arthritis tends to come in different patterns. It's not all one size fits all pattern of arthritis, because people aren't always built that way. So arthritis tends to accentuate those same patterns. So if you start off a little bow-legged, you tend to get arthritis in a pattern that makes your bow-legged a little worse. If you happen to have a kind of a straight limb, your limb may stay in the same straight position. Or if you're knock-kneed, it may progress a little bit worse. So here's some examples of that. This is a patient of mine that has a bow leg to them. So this person probably had a little bit of bow leg to begin with, But then they started to develop arthritis, and the inside part of the joint started to narrow. And so their knees, the bones start touching. You can see, oh, there's some space over here on the outside part, but the inside part of the joint, there's definitely bones touching. And that gives you that bow leg appearance. You look at a straight leg. So this is someone who has arthritis on their, it's more prominent on their left knee. You can see that the limb is overall pretty straight. So it's following along that same pattern. And then if we go to the knock knee example, so somebody whose knees kind of come towards together, the outside part of the joints tends to wear a little bit more than the inside part of the joint. So if we look at that and know that there's these three patterns to the arthritis, then we know that there's something that we need to do to address this. Well, how do we treat arthritis? Well, if you fail conservative treatment measures like injections, physical therapy, anti-inflammatories, Tylenol, there's some different creams, there's different lotions you can try, muscle creams, all these things are failing. Well, at that point, and it's impacting your life significantly, we think about knee replacement surgery. So total knee replacement surgery is where we remove the worn bone and cartilage and put a metal and plastic implant in there. And how do we do that? Well, we make cuts along the bone. There's the femur bone towards the left. We make specific cuts to fit the implant, and we place the implant on and grout it on there with cement. And the same thing on the tibia side, we make a cut along the tibia, and then we place this metal implant with a plastic piece in between, and that forms a new knee joint. And so the knee is essentially resurfaced. Well, the important part about that is, so do we all do knees all the same? Are they always done this exact same way? Well, there's what we talked about earlier. There's those two main philosophies essentially with when you do a joint replacement. The conventional way is to say, it doesn't matter if you're bow-legged, it doesn't matter if you're knock-kneed or if you're straight. We're going to put this knee in the exact same way every single time, because what they do is they cut the bones in the same average alignment. So the cuts on the bone always are in the same exact angle. Doesn't matter if you have a specific knock-knee or bow-leggedness. So we always cut the same way. Well, what is that important? Because that disrespects our natural anatomy. We're shaving off the ends of that square peg and forcing it into the round hole. So if you look on a femur, there's a pattern that happens with arthritis. There's the worn side, so the cartilage starts to wear away. And frequently, the other side of the knee may not be affected or not as affected as the side that it predominantly is in. So in a knock knee, it would be on the inside part of the knee. And so the knee is cut just based off of an average. It does not care about what the natural joint line is, which is this lighter line along here, where the joint line used to be. They just cut along an average. And then we take on the tibia side or the shin bone side, there's the joint line. This is the position that you would make a cut if the joint line is being respected here. And here's our joint line, but we just make a cut that's based off average, and we try to make it perpendicular to the tibia. That's the conventional way and the conventional thinking. Well, why is that important? Well, when you do it that way and you don't respect the joint line, once you've made your bone cuts, the ligaments will not appreciate those bone cuts. And when you try to put the implant in, you've now distorted the amount of the space on each side of the knee. So when you put an implant in there, you have to have space for that implant. And if you cut it and it's just on averages, you know that you've maybe overcut on one portion of the knee and undercut on the other side. And so in order to make that work, you actually have to release ligaments on one portion of the knee or tendons. And this creates an imbalance that in your knee that you have to force it into the position. So you're taking a knee and making it fit your cuts that you made on there. Why is that important? Because it causes more pain. As you can imagine, if you have to release or force something into a position that doesn't want to be in, that's painful. It causes a slower recovery, and it makes your therapy more difficult. You may have talked to patients that have had, or other friends or family members that you may have known them, or maybe you've had it personally done with this conventional technique, and you hear about the no pain, no gain therapy, and you got to push it. If you're not crying, you're not trying. That, I think, is the wrong approach to doing this. And I think if you respect the kinematic alignment, you can have a better outcome. So is there a better way? I believe so. And that's with kinematic knee replacement technique. This is the way that I do a knee replacement. I believe that we should respect anatomy. And so if you have a knock knee, we have to be respectful of that. If you're straight leg or bow legged, we should remember that. We should know that, and we should take that into consideration when we're putting your knee replacement in. Don't make your knee accept the knee replacement. Make the knee replacement fit your knee. So this is the way to do it, is to position the joint in its natural position, which restores its natural relationship, which helps it to bend better. So when we look at a knee on the femur bone, we have that wear pattern. We're following that lighter line. We see that that line is tracking across its natural joint line. This little dotted line is showing where that cartilage used to be. And we know that based off of studies that the wear pattern is very predictable. There's 2 or 3 millimeters of bone or of cartilage wear or small amount of bone wear on that portion of the knee. And we can see that by filling in that space that we cut off, whatever bone that we cut off, we replace with the implant, the same thickness, we're going to restore that natural joint line. So we make that cut along those same lines of what the knee wants to have for as far as its joint line, and we restore that joint line. When we do that, just as on the tibia, you can see here's the joint line and here's the cut that respects that joint line. We put the implant in, it's going to keep that same position, which allows it to bend and straighten better and allows it to feel more natural because we're respecting what the joint wants to be. So using our other diagram that we had before, you can see someone who has a knee that's called varus, which is the bow-legged deformity. We leave that joint line and we respect that joint line the way that it wanted to be like before it had arthritis. If you're more neutral, you have a neutral alignment. And if you have more valgus or what's called knock-kneed, we respect that. We position that implant. So that means that when I'm doing a knee replacement, I don't release ligaments, I don't release tendons, and I don't create that imbalance. So that allows for a faster recovery. We have less pain, and therapy is usually a lot easier, it's safer, and it's more natural. So people are getting their bending back much faster than using the conventional methods. And so you get a happy patient that has a knee that's done that respects their joint alignment. So here's our gentleman from before, his x-rays with the big bow leg to him, and we replaced his knee. And you can see on this x-ray that it's respecting his natural joint line. We have our joint line matched up perfectly. That leads to a happy patient and a fast recovery. So overall, I'd say one thing I want you to take home with is that I apply the same principles to every joint replacement that I do. I use minimally invasive techniques. I try to respect the anatomy and restore it back to as close to what your native anatomy was. I also use techniques that allow for patients to have rapid recovery, and frequently, I'd say the overwhelming majority of my patients go home the same day and sleep in their own bed that night or the very next day from surgery. So my mission is to provide excellent compassionate care to all of my patients and improve the quality of life. And most importantly, get you back to doing what you love to do. So the other techniques that I use beyond kinematic total knee replacements is partial knee replacement surgery. I do an anterior minimally invasive hip replacement. And with that, I use a bikini skin incision, which respects the anatomy of the skin on the hip. So if you want to learn more about that, or talk in specific or answer any of those specific questions, I'd be happy to do that. I'm located at the Cleveland Hip and Knee Institute. It's in Beechwood at Beechwood Medical Center. And now's the time I'd like to answer any questions that we may have. And our number is here listed as well, that we can get you to call in and make an appointment. We'd be happy to schedule to see you. Kelly, do you have any questions that are listed?
I don't see anything in the chat. Does anyone have questions? I think it's okay. I mean, if we can all be respectful enough to unmute if you want to ask verbally.
Sure. Let me
I think that's okay.
stop sharing that. So we can, so I see, so, okay, let's see if we can do that. So
I have a question.
There you go.
Carol.
Hi, Carol.
Hi. Dr. Gobisi has operated on me 3 times, so I'm familiar with your place. Is this similar to conformis?
So great question. Conformis is a quote patient specific implant.
Right.
So conformis was designed that's a specific brand of implant that was designed. The philosophy is to try to put an implant that matches what your knee is like to make the implant match your knee. And so this would be different. And the idea, I think the concept is a great concept on the surface, that you make an implant match a knee. Problem with that is that if you're still using the same technique, which is you cut everybody exactly the same, and you put a knee in and you match a knee that's arthritic. So when you put a knee replacement in that's patient specific and you have arthritis, you're restoring the arthritis knee. You're not restoring the natural knee, the knee that was like before it had arthritis. So, could there be some improvements in that? And if their targets would be towards aligning the knee in the way that's more natural and restoring the pre-arthritic joint line or position of the joint, I think that could be a significant improvement and room for improvement with that. But the design of the implant itself is kind of, I don't agree with that technique of trying to put the implant in that kind of almost like restores the arthritic knee. I don't like that concept. I want to restore it back to what it was like before it had the arthritis. So
what do you do before the surgery? Does the patient have to have an MRI, X-ray, CAT scan?
Excellent question. So every person that I see, I get X-rays. The first consultation, I'm happy to review any X-rays that you may have had in the past. Certainly everybody comes in with a different, what they've had or experienced, but I usually get X-rays at that office visit. And certainly before the surgery, I get a set of X-rays that looks at that alignment, that position that you saw, those the diagrams of the alignment. I do an X-ray film, a special X-ray film that looks at that alignment before surgery.
Okay.
But there's no special CT or MRI that's needed to do this technique. I use calipers in surgery, and I measure the bone cuts during the surgery with a caliper that I can measure down to 0.5 millimeter in size, to get it to position it the way I want.
Micrometer.
Excellent
Okay.
question.
Thank you.
Yes.
Thank
So
I've got a question.
yes.
A couple questions. First of all, is this covered?
I'm sorry. I think you accidentally got muted there. Let me see.
There we go.
Okay.
Got better?
Yes, that's great.
Yeah, sorry. Is this covered by insurance like conventional knee replacement, or is this considered like an experimental treatment?
No, it is not experimental treatment. It's completely covered by insurance. Is the same type of procedure code is how insurances view it. This is fully FDA approved techniques. This is not experimental in any way. Actually, the founding father of this alignment technique and the surgeons that developed this technique, I actually learned this directly from them. Stephen Howell has published mountains of data about this, has been doing this procedure for a long time, years and years of data on this, and he's one of the one that spearheaded the FDA approval of these techniques in these specific categories. So it's well accepted a technique, and again, like I said, it's FDA approved. So yes, it is completely covered by all insurances.
Okay, so you sort of answered one of my other questions about how long this has been around, but also, like I know certain I've had Gobeezy do my shoulder twice already, so I know that it doesn't last forever. Is there more longevity on how this lasts through the years with this kind of procedure?
Excellent question. So yes, the idea behind knee replacement is the hope is that you're selecting patients and doing their techniques so that it lasts your whole lifetime. Now, nobody, of course, can say for certain that knee replacement is going to last, because there's reasons that it could fail that are outside of even technique purposes. But one of the areas that's been improved in the most, which you saw with knee replacements, why they were failing earlier, was the plastic parts that were in. So the plastic was wearing out, and it was because of the way that we processed the plastics. And this is like 30, 40 years ago that this was going on. Since the last probably 10, 15, 20 years, depending on, specific implant, but almost everybody now is using the plastics that are showing that they're lasting much, much longer. So some of the oldest of the oldest ones of the newest plastic, those with retrieval studies, meaning you look at them after, somebody's had them in for, over 20 years and unfortunately they pass away for other reasons. They look at that plastic or they measure it with a special x-ray, and those are being shown to last and not have wear on them or any significant wear. So we don't have 40-year data on those knee replacements because that plastic hasn't existed that long. So that's one thing. The other thing is that there is some compelling studies done by Dr. Howell's group, and they look at the positioning of the implant and does the implant positioning predict longer survival. And with his studies and a couple analyses that he's published both this last year, and there's another upcoming study that he's going to be publishing that he reported on that show that the kinematic alignment has very good survival rates with this and compared to the conventional techniques, and that they were not seeing the same lucencies or plastic wear and the wear into the bone that were concerns for knee replacements, especially early on knee replacements.
Yeah, I just got one last question, a quickie. What's the typical downtime for somebody who does this?
Fabulous question. Yeah, so the knee replacements surgery, I usually say it's a 6 or 12-week recovery process for a knee replacement. But since I've been doing the kinematic techniques, I'd say that you can almost have that. I mean, by the time I see people in office, around the 3 to 6 week mark, I've been following patients and they're in that point. They're doing much better than what they were before. I mean, I'm regularly seeing patients in office where they're bending their knees like to points where, I mean, with the conventional methods it would do them, and the bend would be like at like 6 weeks. I'm seeing it at 1, 2, and 3 weeks. They're getting their bend that fast, the bending back. So it's really impressive, the difference. So I've been seeing that accelerated, and I do a lot of partial knee replacements as well. And I do still believe in partial knees. I think they're wonderful when they're indicated. And we actually have another webinar on partial knee replacements. And I'll probably repeat that so that the recording works better. I think we might have had technical difficulties with that one.
We did.
Those knees, they recover really fast. They're very, very well known for recovering fast because it's a part of the knee joint that we're replacing. My knees with the kinematic technique, they're really approaching those partial knees. I mean, I'm getting them come back in. I'm like, wow, that looks like a partial knee. Like that's how well they're recovering. They're bending their knee so well, and they're getting along, and the pain and the pain scores and everything are matching those knees. So it's been very impressive.
Thank you.
Mm-hmm.
Any more questions, anyone?
So excellent questions. I am so grateful for everybody who came on. If there's
I have a question.
Oh, yes.
Will you be doing this again, this Zoom meeting? Because I have people I want to get on here for you to talk to them.
Yeah, I would be very happy to do another webinar. My plan is to do several. I'm trying to cover different topics of my practice, right? So partial knee replacement, a total knee replacement, total hip replacement. I do a direct anterior minimally invasive technique with that. But I'd be happy to repeat the webinar. We are recording this webinar right now. So the idea is to be able to broadcast that to someone who hasn't been able to see, so they can watch and especially for everyone who's participating, it's nice to be able to pause it and then go back like, what did he just say about that? Because when you're listening to it live or looking at the pictures, and it's nice to go through on your own pace. So we'll have that too. But
yes, I'm gonna email it to I'm gonna post this and email it to everyone so they can have it in their email inbox and see it, and then it will also be on our website.
Thank you.
Absolutely. And then I definitely am looking forward to doing more of these. This is something that I'm very passionate about. So I love taking time to talk about this and answer people's questions. And certainly I know there's a lot more questions you could ask, especially because there's more personal type questions. That's a great time to get, an office consultation. I'm happy to do those and to answer any of those personal questions. And the one thing I always tell everyone is just write down your questions, because you're going to get in the office and you're going to get like that, like, I don't know what question I had to ask. I had it in my head and it's gone. Just write it down. I'm happy to answer it. And, even if it comes later, you can give me a call. I'm happy to answer that too. Okay, well, if there's no more questions, thank you so much for your time and attention today. I really appreciate it. We'll make this webinar available. Kelly will shoot out an email with the recording, and we'll try to make it available on the website as well once it kind of gets, edited a little bit for clarity and brevity. And we'll get it up there. Thanks again for your time, attention, and hopefully I look forward to seeing you soon. And have a great day.